Okay, guys. Hello, good evening. Happy day before Valentine's Day. I'm Dr. Anna Berik, and I'm going to be talking to you tonight about Propel, Micro-Osteoperforations, and the Pro 5 device. I own a practice here outside of Boston. I'm a Platinum Invisalign provider. I went to Tufts University for dental school. There's my boy Frank, my dog. And tonight we're going to try to take you from any level that you are currently performing Propel at, and for newbies in that you'll be able to start tomorrow. That's my goal. I'm not an employee of any dental company. I don't own stock. There's disclosure. I don't have family that has stock. So you can read through the disclaimers. I kind of have to put this up. And so let's get started. So BAM, the Berik acceleration method. I'm going to take you through the basic science and understanding of propellant mechanisms. And I'm going to tell you how I've integrated it and incorporated it in my office. It's a very successful system. So let's think about acceleration for a minute. I asked Siri, what's acceleration? And Siri came back with, it's an increase in the rate of speed of something. Physics-based definition is the rate of change of velocity per unit time. But I really want to know, how flippin' fast can I move a tooth? Well, we need to think about, certain aligner companies. Invisalign came out and announced a 7-day wear for the tray. Well, how do you decide what cases, 2 days before the announcement were 14-day wear and what 7-day? And what do you give up by that? Other ways to accelerate are munchies or chewies. For those of you who don't know, they're firm pieces of rubber that are tray seaters. You bite on these little piece of rubber that you give to your patient, and it seats the tray down over. Oh my gosh, the buttons there. Vibrational technology. These are your Pro 5s. We'll get into that a little bit tonight. Manual osteoperforation. This is the Propel system, and it is phenomenal. And this is what we'll spend a good deal of the next hour looking at and talking about. Acceleration can also be done by surgeries, orthodontics, piezo-excisions, and photobiomodulation. BioLux has a product called OrthoPulse. Those are the ways in which we can accelerate. So my journey with acceleration started here with this Brian Gray article in Dentistry Today from 2014. And he's comparing accelerated orthodontics with the different ways that we've just discussed. If you look at this chart, the key, really simply to just kind of brief over it, 0 is none, 3 is high. So when I looked at the different ways to accelerate, I went to the far right-hand side of the chart and I looked at effectiveness. Because it's not effective, I'm not even interested in reading about it. So Acceladent, which represented vibrational technology in 2014, was a 2, pretty medium in terms of effectiveness. The chemical pharmaceuticals, BioLux, none of those types of laser-assisted treatments were effective at all. Orthodontics and piezo-excision, very effective, and Propel, very effective. If I went over and I looked to the left at the cost, Acceladent was very expensive. Back in the day, they were $1,000 a unit. And then Orthodontics was pretty expensive. Piezo-excision, pretty expensive. Propel, inexpensive, a low cost. So when I put together the two factors of that, micro-osteoperforations and Propel were the most effective and least expensive treatment options, I just needed to read on. For me, that was enough to want to know more. So we're going to talk about MOPs and clear aligners, and I'll use Propel and Invisalign interchangeably for the words MOP and clear aligners. So let's look at the devices. The device to your far left, the single-use appliance, no one uses really anymore. It was really Propel's first generation. The device in the middle is called the RT. It's a manual driver. The light blue portion at the top is the tip, and these are disposable, 1 use per patient. I did my first 75 cases with it. It's phenomenal. I keep it around the office just in case my other device, the device to your far right, called the PT, and device, in case I lose charge or I've got a lot of patients in a row. Sometimes you just want to put one aside or two. So I still use it to this day, but I upgraded to the PT where the handle is reusable and the tip is just that single burr you see on the contra angle. It's very, very quiet. It sounds like an Oral-B Braun toothbrush. It just hums a little bit in the background. The contra angle is phenomenal to reach into the back. It's a little harder with the RT, given the straight nose cone look of it. So those are the devices that we're going to be talking about tonight. So let's talk about manual osteoperforations, MOPs for short. 2 benefits to this. You're going to accelerate, you're going to move faster, but the more important one sometimes is that you're going to increase the predictability of orthodontic movement. You're going to help difficult movements achieve their actual motion. So when I talk to patients, it's really, I put up 2 fingers and I say, 2 benefits to Propel. 1, we're going to accelerate the treatment time. We're going to move faster. 2, we're going to move better. You're going to move faster and you're going to move better. Those are the words that you're going to use with your patients. And really, really, you're going to emphasize to them that it's also moving better. So let's look at the science behind manual perforations. How fast can we move a tooth? When we're thinking about, is Invisalign right? Is a 7-day tray change possible? You know, what factors affect tooth movement? Well, the type of movement. Are you tipping? Are you rotating? Are you intruding? Are you torquing? What type of orthodontic movement are you doing? That affects the rate at which you can move. The amount of force. For us in the clear aligner world and Invisalign, it's a wash because each tray has the same amount of force. If you're placing brackets and wires and you can use this system in either, then the amount of force, what's the force on the wire you're using? The patient's bone density or bone quality affects tooth movement. You know, are you dealing with a little osteoporotic old woman, or are you dealing with a giant man with a bone like granite? You know, this affects the rate of tooth movement. And the rate of bone remodeling also affects tooth movement. So out of these 4 factors, type of movement, amount of force, bone density, and the rate of bone remodeling, the most important and significant factor is the rate of bone remodeling. This is really the rate of bone remodeling controls how fast we can move a tooth. So bone remodeling is controlled by an enzyme in the body called cytokine. It plays a huge role in activating those osteoclasts and those osteoblasts. So the cell eaters and the cell formers. And then this is in the way that which it plays such an important role in accelerating our tooth. The other factor that plays a big role is the role of inflammation in tooth movement. What we do know is that anti-inflammatories, these are your NSAIDs and your Motrin type medications, anti-inflammatory medications significantly decrease tooth movement. And we know also from animal studies that if you knock out that enzyme cytokine we just talked about a minute ago, that this significantly decreases the rate of tooth movement. So in a nutshell, I love this slide. This is the science behind Propel right in front of you. So bone injury causes inflammation on a cellular level, which increases the patient's cytokine production, which also increases the rate of bone remodeling, all that little osteoblastic and osteoclastic activity, and it decreases bone density. This is a recipe for good tooth movement. You're going to have fast bone remodeling, lower bone density. We can move teeth through this. So we already knew this, though. This isn't new. Procedures like wilchodontics and episiotomies have been around, and they speed up ortho treatment. We knew this, but they're really expensive. It's full-blown surgery. You need normally someone else to do this. It's painful. There's a recovery time, and if you look at the slides, hopefully you're not eating dinner during the webinar here, but you know, this isn't something that patients are jumping on board saying, yeah, I'd love to have this done. So the primary research, one of the first articles to come out on these manual osteoperforations is in the American Journal of Orthodontics from November 2013. Great article if you care to read it. This is why I put up the primary page. But what we're really looking at, I can discuss with you in 2 slides. This slide, let me set up this NYU study for you. This is the same patient to the left and right of your screen. What they did was they extracted a premolar, and the goal here is to distalize the anterior segment. So we want tooth distalization. We want teeth translating distally, translation, bodily moving roots through bone. They've set up a TAD device, you can see this. And so this is the same patient. The slide to your left has just the TAD and the attachments and the brackets and so forth. The slide to your right, if you look very carefully, and it's pretty clear on my screen, right around the canine, you can just see a little bit of redness. Those are micro-osseous perforations. I'll also point out that keep in mind, if you look at this slide, you don't really see any past that first 1 or 2 right around where the missing tooth is, because you're not going to perforate around your anchor teeth. In this case, the TAD is an anchor. So here it is, and then 4 weeks later, they brought this patient back. And again, if you look to the slide to your left, kind of where he decided not to brush his teeth, there's a lot of schmutz over there, you can see after 4 weeks, we barely see anything. But if you look to the slide to the right, the one that did receive just 2 micro-osteoperforations, you can clearly see that canine distalizing. So this is in 4 weeks. It's real, the movement's happened, it's been in an accelerated period, and it actually moved that tooth through bone in translation. So there's no great place to put in the contraindications to micro-osteoperforations, so we're going to discuss them right here, right up front. They are, you will see as we discuss, they are the same contraindications to moving teeth orthodontically in the first place. An ASA class 3 patient is the American anesthesiologist. So this is the people that put you to sleep before your surgeries. They grade patients. ASA 3 is a systemically compromised patients. These patients are having multiple systems failing. These are hospital patients. You're probably not going to treat them with orthodontics at this point in their life anyway. Patients requiring chronic NSAIDs or steroid treatment. Your lupus patients, you got to look for NSAID patients. And patients who are treated with bisphosphonates. Bisphosphonates are bone density increasers. They hold bone density. Again, these are contraindications or at least rate limiting factors for regular orthodontics. So these are your same contraindications for Propel. So let's get started. Let's look at how to do this. You're going to start with an FMX. I pulled this one up off the web. So you need an FMX so you can see where the roots of your teeth are located and look at the surrounding bone. You're going to also start with your movement assessment chart. For those of you who don't know where to go for your movement assessment chart, in your patient VIP, your doctor VIP, you go to your patient, and when you pull up your ClinCheck, you hit right here, treatment, that little box that says treatment. And this is what comes up. And you will see that there's a model of your teeth. The teeth that are missing have an X. You'll see the teeth that are clear. These are pretty straightforward movements. These are pretty predictable movements. When you look at the teeth on this chart that are in blue, those are moderate movements. And when you look at the teeth in this chart that are blacked out, 2021 in this case, these are advanced movements. These are difficult, less predictable movements. If you start with your first patient and you take your x-rays and you look at the roots and the bone quality, you look at the teeth you're moving and the degree of difficulty, we can begin to put together, one, where we'd like to place our micro-osteoperforations, and two, we'd be able to put together, am I moving this in 3 days, 5 days, 7 days? How fast can I proceed to my case? And I intend to teach you that tonight. So you will track or you will move teeth no faster than the rate limiting tooth. On our previous slide, you're going to see the rate limiting tooth are 20 and 21, the advanced movements. Those teeth are actually the hardest teeth to move in this patient, and those teeth are the rate limiting factor for my case. So sometimes it's only just a tooth. Sometimes you've got rotations in all of your anterior teeth, but the most difficult movement that you're performing in the mouth, either by degree of rotation, amount of intrusion, or just simply the degrees of it, that will be your rate limiting tooth. And if you know what that is, you're going to be able to make these assessments on your own. So this is how you begin to make this determination. You're going to check your movement assessment type. You're going to look at the type and amount of movement, and you're going to go 3, 5, or 7 day aligner wear when you accelerate your case with Propel. So let's look at, okay, well, how do we know what are easy movements and what are hard movements with clear aligners? Lingual constriction or anterior space closure. This is an easy movement. When you have space and you're pulling the teeth in towards the tongue, that's lingual constriction or space closure. Those are really predictable movements. On our movement assessment chart, those would come up as clear. Proclination, tipping, or reclining the teeth. All of that is tooth tipping, controlled tipping, and it's very, very predictable in aligners. Premolar expansion, also something we do quite commonly and is very predictable. What are difficult movements? These are your rate limiters. When you come up with teeth that root torque, the crown of the tooth moves in one direction and the root moves through bone in the opposite direction. Root torque. Difficult movement because you're moving a root, and a lot of times these are lower canines, so we've got some sizable roots here. So those are less predictable movements. Maxillary anterior intrusion. These are your deep bite cases, aren't they? These are a lot of your class 2s. You're intruding 8 and 9, for example, 2 or 3 millimeters. You're pushing the apex of that root through solid bone. That is a difficult movement, made much more predictable by the use of propel acceleration. This is also the reason so often why we lose tracking on the laterals, right? If our maxillary anterior, say 8 and 9 in our example, fail to intrude, then they lose tracking on the laterals. It just, the plastic pulls off the laterals because we haven't translated that movement. AP changes, molar translations. So AP changes, you're correcting class 2, class 3 cases. You're making anterior, posterior changes. Also, more difficult movement. Often we use elastics for cases like that. Other types of devices, your carrier appliances. So these are more difficult movements and less predictable. Here is where you're going to really appreciate the benefit of using some micro-osseous perforations. So where do we put these? How many and where? This is always a question I'm asked. So the basics, you are going to place micro-osseous perforations to the left and the right of the root of the teeth you wish to accelerate. So in a case where we're going to start and we're going to tell the patient we're going to accelerate this case, we're going to go into 5-day wear, you go around all the teeth you're moving. If you're not moving molar teeth, do not use any propel around the molar teeth. If you are using the posterior teeth as anchorage to close up space in the front, you're not going to propel around those teeth. You're going to place them in the keratinized tissue, the pink bound down tissue. It is not a law. You can certainly place them in mucosa. I get asked, what if the tissue is really thin? My suggestion here is that when you go to mucosa, it's a little more difficult. You need to literally, with your fingers, pull that mucosa tight so that the tissue doesn't wind or tear around the device. The most predictable is to go into keratinized tissue. That's our preference. You're going to do 2 to 3 micro-osseous perforations per site. Certainly in areas where you have access. We'll talk about areas where you don't have access that's as nice. On the anterior segments, your front teeth, you'll go about 3 millimeters in depth. Premolars, you'll go about 5 millimeters in depth, and the molars about 7 millimeters in depth. I will tell you those anterior premolar and molar depths are a guideline. Really what you need to do is break the cortical plate of bone. You can feel this. You can feel the device literally go through the tissue very easily, and then you'll feel the device engage. Those of you who do implants, you'll understand that it is literally when it engages in bone, it starts to pull your instrument in. All you need to do is break that cortical plate of bone. That's all that's required. It's so simple and relatively quick. But this is a guide. For your first one, of course, everyone needs to have some understanding to begin with. You will have that tactile sensation, and you will understand what I mean from the moment you do your first case. So let's look at where to perforate. If you look at the little tooth on the bottom, this really gives you a lot of, the slide itself gives you a lot of information. But what I will tell you is that the slide at the bottom, you're gonna put your micro-osseous perforations, like I said, to the left and the right of the teeth you wish to accelerate it in the keratinized tissue from the crest of bone to the apex. You're not going to go below the apex of the teeth, and above the crest of bone, you're going to put these into bone, so that's kind of silly. Anywhere you can slip 2 to 3 perforations in there. Your x-rays become very important here because you're going to want to review your x-rays to make sure that you know where the roots are located. This slide's very, very busy, but my point to myself when giving this lecture is to tell you guys that you can use Propel proactively, which would be at the beginning of a case. You and your patient have discussed, we're going to use the micro-osseous perforations to move your case faster and to move your case better. Moving faster, moving better, those difficult, rotations, Mrs. Jones, we're going to make those actually work for us by using the system. But you can go in tomorrow and look at a case that's not tracking, a current case that you're doing 14, 7 days, whatever you're doing, and you can say, my canine is not tracking. You can actually apply Propel around a single tooth to catch that tooth up, to wake up a tooth that's not moving properly. You would continue on with your 7 or 14-day wear, whatever you're doing, and that you will see the tooth actually start to move better for you. This is phenomenal because it's really going to save a case that loses tracking mid-course. Maybe you don't have to do a mid-course correction. Maybe you don't have to do additional aligners, which we know takes more chair time. It disappoints our patients because it prolongs our treatment promises. So it's really wonderful. You can go in and use a reactive approach. Perforations, the number, pattern, and spacing. Again, we're going to look at the bone down there. No one's molars are separated like this, but if you look at the little picture on the bottom, you can go vertically 1, 2, 3. You can put them in a triangular pattern. You're going to go where the roots of those teeth and space allows. 2 to 3 perforations, mesial and distal of all of the teeth you'd like to move. So the other really wonderful benefit of this is that your micro-osseous perforations have a radius of effect, which means that from the site they're given, you have 6 to 10 millimeters. And remember, radius is round. It's not just mesial and distal. It's also buccolingual in direction. If you picture a ball, a circle, the radius all the way around, you have a radius of effect. So when you have a case, perhaps you've got maxillary lateral that's blocked out between a canine and a central. You can give a micro-osseous perforation to the palatal, but a lot of us tend to not give a lot of palatal things. The palate tends to be a sore area, even if you anesthetize it. But if you can put 3 micro-osseous perforations sort of to the distal of your central and the mesial of your canine, right where that blocked out premolar is, you'll get this radius of effect, which will allow the bone to remodel much faster right around that lateral. It's beautiful. The other area where this comes up frequently is when you have super crowded lower anterior teeth. All those little incisors, sometimes they're just all packed in so tightly, and you look at your x-ray and you're like, wow, I don't have a lot of interstitial bone here. Where am I to go? If you can even get 3 perforations to the mesial of the canine, 22 and 27, you'll get this peripheral effect from 6 to 10 millimeters. If you can sneak in 1 micro-osseous perforation somewhere, or maybe even one between the centrals, you've really covered that whole area. That is now an area that's been treated and will accelerate for you. The other thing I want to mention is the duration of effect. So within the first 24 hours, your cytokine is spiked. Within 10 to 12 weeks, the effects are totally gone. This becomes very important. People ask me about retention. You have to retain them longer or change that. No, your retention protocol stays the same so long as your case goes 10 to 12 weeks. Sometimes you'd be surprised. Some of these cases with 14, 15, 16 aligners, you'll finish in under that 12-week period. In that case, I keep the patient in the retainer or the lax tray an extra week or two. But the duration of effect, 10 to 12 weeks. If you have a long case that runs 35 cases, you'll consider reapplying Propel somewhere midway between it, around week 10, 12, whatever seems to make the most sense for you and your patient. So use your movement assessment chart. Pull it out. You're going to look at your blue easy movements. You're going to look at your black more difficult movements. You're going to use micro-osseous perforations on both sides. Keep in mind that there's a radius of effect, 6 to 10 millimeters circumferentially, which will really help you. Again, that example of the little mandibular anteriors where all the roots are crowded together, you're okay there because you've got this peripheral effect. If you can get them some micro-osseous perforations, even into the mesial of the canines, you'll cover that area. You'll feel comfortable in those teeth moving for you. This is a chart showing the depth, but if you look at it, all that's necessary is to break that cortical plate of bone. So there's your 3 millimeters anterior, your 5 millimeters around the premolars, and your 7 millimeters around the molars. So to start the procedure, you're going to review your treatment plan. You're going to review the movement assessment chart. You're going to look at your x-rays, and you're going to numb the area to be treated. Propel will tell you that you can use topical anesthesia or local. I will tell you what I do in just a moment. You're going to explore the surrounding tissue thickness. And this is part of that 3, 5, and 7 depth, because tissue gets a little thicker as we go back. You're right up front, the tissue is thinner. And then you're going to have your patient rinse with chlorhexidine for a moment. Your Propel reps, when you're going to do this for the first time, will give you instructions to help you through this, but you're going to have your patient rinse with chlorhexidine. And here's what it looks like in a slide that Propel offers to their doctor, so you can see it. Evaluate the treatment area, have them rinse, anesthetize, and accelerate. Post-treatment instructions, you guys may want to screenshot this. You know, there may be some tenderness around the site for 24 to 48 hours. My experience is that they don't have tenderness. Really, it's those first sets of aligners or the first engagement of the wire on a bracket case that where you're really, that's more tender than the Propel site. Patients should not take any non-steroidal anti-inflammatories or any steroids for that matter. We recommend Tylenol or regular aspirin for the 10 to 12 weeks. It is for the whole 10 to 12 weeks that they are on it. An additional perforation may be repeated in 10 to 12 weeks as needed, and your post-treatment instructions are similar for anything that you would give for a local anesthetic. So don't bite your cheek, don't do this, that sort of thing. Mainly the big takeaway here is they could be a little tender, take a Tylenol, it wears off in 10 to 12 weeks. So bam, let's talk about how I do this. So I'm going to show you my 6 steps and we'll break it down and talk about each one. So when a patient comes in, I'm going to give them some pre-treatment information written. I go over it, but I give it written. I'm going to numb the patient. I'm going to do all of my aligner prep. These are our attachments and our IPR. I'm going to demonstrate how to take the trays in and out of their mouth. I'm going to perform my micro-osteoperforations, and I'm going to give post-op instructions, and then I give the closing. That's it. Those are the 6 steps. I do this in 1 hour. So in advance, you prepare your patient. At the records visit, when I'm scanning, I talk about acceleration, and the patient leaves with everything I talk about on a pre-op instruction sheet in their hand. It keeps me honest. I don't forget things. I don't get distracted. They have it in writing. Patients like to refer back to them, and it's so nonchalant. Patients know what to expect. I think that's really, really important. I do Propel. People always ask me, I perform all my MOPs at the first visit when I deliver my first sets of aligners. So in my office, I have a scanner. My patient scans, and I take my photographs. A couple weeks later, when they're coming back for the delivery visit, this is when I'm gonna do all of the care up front. I'm gonna do all my MOPs. So when a patient walks in, the first thing I do is numb them up. And I really believe this is the key. I know Propel says that topical is great, and I think they're doing that out there for the orthodontists in the crowd who don't give a lot of needles. For the GPs in the crowd, we've got a needle in our hand every day. I really use lidocaine. I actually use Cytokines. I give about 1 milliliter around each canine, upper and lower, and then maybe just a drop more, a little distally or a little mesally, depending on how far back your case goes. But within 2 carpules, I've got my patient completely numb, and I'm comfortable giving them. They don't feel a thing. Patients are more comfortable, you know, from the time your patient goes, oh, or squeaks at you, you pull back, you're nervous, they're nervous, numb them up and forget about it. You and your patient will be much more comfortable. The additional benefits too is with that use of a vasoconstrictor, you just don't end up with bleeding. It's really nice. And I'll tell you, for those of you who look at IPR when we're doing aligner therapy and you sigh because patients hate having the little strips between their teeth and whatnot, it really makes it a snap. It really makes the IPR so much more comfortable for patients. You'll be more confident and feel more secure going in and doing your IPR. So those are the benefits to that. I like numbing patients up. I numb all my patients. So step 3 is the aligner prep. So I have the patient rinse with chlorhexidine as directed by Propel. I place all my attachments while they're numbing up. So I've given my anesthesia, I put my attachments on, I perform all my IPR that I can get away with at that time. You know, sometimes you do have to wait just based on tooth position, but I often have a lot of my IPR. I structure that where I'm going to get that before aligner 1. So I really go in and do a lot of my IPR. And again, way more comfortable with a numb patient. Then I demo the placement and removal of my aligners. Once I do my micro-osteoperforations, I don't want the patient to pull trays in and out and in and out. I want to do my micro and then leave the tissue alone. So I demo the placement and removal of my aligners before I do my Propel. So let them rinse, give your Novocaine, put the attachments, do the IPR, demo the removal and placement of your aligners, and Propel away. So this is a patient you'll see later on in the lecture that I will show you her case. But I took these immediately after, right on the spot. Propel has this chart where you can chart your perforations for your records, but I don't have any paper in my office. I'm digital. So I figured, well, you know what? I've got a camera that I use every single day. So I pulled up my camera and I took a picture of where I did my perforations. These are very, very clear pictures. I have a Mac lens on that camera. It's a sweet camera. And what you will see in this is that I already have my attachments on. My IPR is done. And I've taken pictures of you don't see bleeding at these sites. You know, I never knew I was going to end up giving a lecture for this procedure. So I took these for my own records. This patient's not bleeding. You know, there's a lot of misconceptions about how intrusive this is, and it's really not. People complain about IPR way more than they complain about micro-osseous perforations. So step 5, I give a post-op instruction sheet. I verbally review the post-op instructions, and they're just the things we talked about a moment ago. I tell the patient, you know, don't touch the tissue, let it all rest until the Novocaine wears off. I tell them Tylenol only for the next 12 weeks, those kinds of things. It's in writing. I deliver it in writing. I also deliver in writing an aligner schedule, and I also write the schedule on the aligner bags themselves. I give my post-op review sheet to the patient. So I go over it verbally and I give a post-op review sheet to them. So the aligner schedule, patients leave with a copy of the aligner schedule in their hand written, and then I write it on the bags. So if you do not know where to have a really clean aligner schedule, if you go to the patient's ClinCheck page that looks like this, if you look down here where the big yellow arrow is, it's pointing to generate aligner schedule. This is super helpful, even in patients you're not going to accelerate. So generate aligner schedule. And when you push that, what comes up is this little form. And on the top, it's going to ask you things like the start date, the number of aligners, and the number of days you're going to be changing trays in. So in this illustration, 32 aligners, they were changing trays every 5 days. And what autofills is what you see below it. It goes to, on the 22nd, the patient started aligner 1. On the 27th, the patient started aligner 2. This is really lovely. Patients really appreciate this because they tell them, don't hang this up in your bathroom and use it like a checklist. Because when you're moving trays every 5 days, which is probably my preferential time for 99% of the cases, once in a while I go 7, once in a while I gotta go a little faster. But when I choose this, I really get good translation of the movements that I want. Patients finish super fast in a 20 in, 20 out case of aligners. It falls right in that 10 to 12 week window, which is great. But when you can tell the patient, you know, this normally takes 8 months and I can finish this in 3, that's a patient that's going to perk up and listen to you about moving their teeth. So it's wonderful. Here's the aligner schedule. Patients really like getting it. You just hit print and boom, you've got all of these. And then we print 2 of these, by the way, at the office. One we give to the patient to take home, and then one we save in the aligner box, because these are the dates we use to write on the bags. We just go right from here. You don't have to hold a calendar in your hand. So step 6 is the closing. They're out the door with 9 or 10 aligners in that illustration of 20 trays in and out. I see them in about 6 weeks. The instructions are for 5-day wear in this case. And my next recall is about 10 minutes. Bam, they're done. So let's think about it. I did a scan at the first visit. Usually we have about 30 minutes for the scan, questions. I spent 1 hour delivering the case. I did all of my attachments, my IPR, my acceleration with Propel, gave all the patient instructions in terms of wearing aligners and all that kind of stuff. And then 6 weeks later, I'm going to see him for 10 minutes. And then 6 weeks after that, in that 20 aligner case, I'm done. I'm removing attachments. Do you know how much chair time that saves? How happy patients are? It's amazing. So let's look at Abby. Abby was the case we looked at when I was demonstrating, hey, look, here's Micro-Osteoperforations. So Abby's a nurse, a lovely, lovely, lovely girl here in Boston. She's getting married. So we take a look at what her teeth look like. You know, we definitely got a deep bite going here. We've got some rotation of that anterior tooth. You can see it more. We've got hyper eruption of the lower anteriors. We don't have a level lower. Her arches are narrow. We're kind of looking at really folded in premolars back there. Class 2 patient, right? Look at the overjet, tremendous amount. So I've got deep bite and overjet. This is about, I don't know, about a 9, 10, 11 millimeter overjet, depending whether you looked at tooth number 8, which is flipped out, or tooth number 9, which is not. So we've got some, you know, some serious issues to deal with. So we accelerated Abby. Rate limiters in this, I've got to intrude 8 and 9. Let's start to work this case together in our minds. What are my most difficult movements? The intrusion of these 2 front teeth is difficult movement. Separating those premolars, not so much of a different movement. Looking at the lower, I want to buccally tip those premolars because that's going to increase my arch. And then I have some little canine rotations, but the limitations to this case, the hardest teeth to move in this case are really to intrude 8 and 9. Here she is after beautiful intrusion of 8 and 9. The case looks great. We did level her lower teeth. I would do a better job of this now. This is before the aligners where you were allowed to put lingual attachments on the canines. Now you can put lingual attachments on the canine to aid in mandibular anterior intrusion. It works great. But when we look at that, I've closed down that overjet. I've corrected, of course, the rotations, but I've corrected that. And here she is before and after. This was a 19 aligner case. It took me about 13 weeks altogether, about 3 months. And I did get great movement on my laterals, and I did get the anterior intrusion. So important things in Abby's case. She was done in 3 months. She was thrilled with that. We did get the difficult movement of maxillary central intrusion. And we achieved all of it in 3 months. You know, we closed down that overjet. It's really a successful case, and she was thrilled. Here's case 1. Let's get a totally different type of case. Still a class 2 case. Here's Anne-Marie, an older patient. You know, she always said that 8 and 9 were dark. Well, if you really look at 8 and 9, they look darker, but what's really happening here, 8 and 9 are retroclined, aren't they? You know, we've got this typical class 2 presentation. So not only do we have to upright 8 and 9 and also recline the laterals, but we're also got a deep bite going here. So that intrusion, those tipping movements are fairly simple. You know, in our case here, that's relative intrusion when we tip 8 and 9, but we're going to also have to straight intrude 8 and 9 into bone. That is a rate limiter. And really, we've got quite a bit of reclining, and I've got some overjet. When you look at 8 and 9 and you in your mind's eye, you can say, okay, so she tips these teeth because they're too reclined at this point. Now I've got an overjet issue as well. So I have a hidden overjet issue. And if you look here, this is tooth 29. 29 is going to be a rate limiter for us. We've got an end-on-end class 2 molar relationship here. Tipping, I've got some asymmetry. We've got some stuff going on. And so here's your occlusal view of the max and the mandibular. So if you look here, tooth 29, this baby is the rate limiter in our case. Our case will move no faster than this tooth. So you better be sure that I put MOPs to the left and the right of the root of this tooth. You know, over here where I didn't have, to the other side, where I didn't have so much of an issue with a locked out premolar, a two-rooted tooth locked out of the arch, you know, I just went to the mesial. I didn't really need to move to the distal of this tooth because I had that peripheral effect. So the most difficult movement here is that tooth. And here's her case to finish. This was the day I took off the attachments. We haven't bleached, we haven't done anything. You can see actually polishing paste here and again. And what you're gonna see is we did achieve the goals on the anterior of intruding 8 and 9 and finding our laterals and bringing them back into the arch for a nice smile presentation. You're gonna look here, boom, there's tooth number 29, back up in the arch where it belongs. We did not move the molars in this case, but I did upright all those premolars. So this case looks great. She's got a lockdown bite, and here's how it flowed. 27 aligners altogether. That intrusion and that uprighting, when we go back and we looked at my movement assessment chart, uprighting that premolar was an advanced movement. That was a black movement. 27 aligners, 19 weeks of treatment, about 4.5 months, and it finished beautifully. I achieved all my goals. So the thing here is that this is a typical case where you see a lot of refinement. You know, what I hear out there is there's 300% refinement rate for most cases. People are going in and refining 2 and 3 times. Think about the chair savings time it takes, because this doesn't just move it faster, it moves it better. Robyn was a really difficult case for a number of reasons. Her front 2 teeth are not shaped alike. We've got some teeth that are over erupted on the lower. We've got that class 2 presentation of those laterals. I have open bite. We have over jet. We have almost a collapsed VO in back to the left and to the right. And so here's Robyn. Robyn presents with a myriad of questions, but if you look at this canine down here, this canine needs root torque. We're going to take it and root torque. We're going to move the crown distally. There's a small rotation in as well. And as we do that, the root is going to move mesially through the bone to upright that tooth. Look at the anterior presentation. We've got some pretty good rotations in here. Fortunately, they're on anterior teeth. And here we go. We've got rotations, we've got uprighting, and you can see the canine locked out here on the bottom. That's a lot of rotation and uprighting to do. It also required root torque. There's my rate limiters right there. Again, I used my Micro-Osteoperforations from the mesial of my second bias all the way around to the anterior. I did not move molars in this case, so I did not feel the need to go distal to that second premolar. The access is easy, takes 5 minutes. And here's the after. So we've really achieved a lot of our goals. We've leveled this bite. We have a completely closed down bite. You can see we still are in class 2. We don't have the same open bite. Our overjet is appropriate before and after. So I did additional aligners because if you look down to my after picture, still that lower canine really just needed the littlest amount of movement back. So I insisted that we go back and we make sure that that canine was in function with its opposing tooth. So we did our initial treatment in 24 trays, 5-day wear, 17 weeks, about 4 months. And my additional aligners, I went 5 days a tray, about 8 weeks. So within 6 months, we corrected uprighting teeth, increasing the vertical height, intruding lower anteriors, intruding maxillary, closing down the open bite with the laterals. It turned out great. She was thrilled, and that's our final case. Katie. So Katie is a really interesting case and a difficult one. At first, of course, what jumps out at you here is the diastema between 8 and 9. People ask, did I do a frenectomy with this? Yes, because her lip beyond the wet-dry border was attached to this frenum. This frenum was like this little pink bat right in the middle of the teeth here. It was so fibrotic and went so far up her lip. Of course, it demanded a frenectomy. But Katie's a young girl. She has nice teeth. I think the other thing to really notice about this is how triangular these teeth are. And that when we go to analyze the case, look at the flare. Look how over-proclined and over-closed she is. And we're different on the left side. You're looking at the right side here. It's almost like the bite is collapsed and back. Her teeth lean so lingually that it's actually decreased the vertical height on this side. And again, look at number 29. Maybe not as bad as Anne Marie's case, but also a locked out premolar. These start to describe, look at this left side, looks more normal in presentation. The height that the uppers and lowers create against each other look more normal. When we start to look at the occlusal view, you'll see that Katie not only has this tremendous outstanding diastema between 8 and 9, but I have asymmetric, irregular space also surrounding the canines to the left and the right. They're spacing everywhere. So this is quite a bit of spacing. And the first thing that 8 and 9 are going to want to do is tip. This is typical in any type of orthodontic movement. When you've got a diastema like that and you're pulling those teeth together, those teeth 8 and 9 are going to want to tip. So what I told Katie on the outside of our case is that, Katie, this is going to come down in 2 rounds. I already prepared her that I was going to move her teeth once and that I was going to do additional aligners at the end, because I knew what would happen. With a diastema that large, those teeth were bound to tip before they translated. So here's that locked out premolar on the bottom that we were talking about. Again, a rate limiter. This takes a lot of movement to upright this tooth. Here she is at the end. She did not have the frenectomy until almost halfway through treatment. So we're going to give this 5 or 6 months for her frenum to grow back. People always ask me about that question. You know, it's just been so recently done because we accelerated this case that we're going to give it a little time. She was thrilled. The other thing that I did that patients, that docs ask about, I also added IPR to 8 and 9. And I know that sounds crazy, but given the triangular nature of her teeth, I knew we'd have a big dark triangle here because we didn't have any papilla to begin with. She had that huge fibrotic frenum sitting down there. So I reshaped these teeth a little bit, and I did it as I went into round 2. I didn't do it in round 1. I let the teeth move. And here we go. This is at the end. She also bleached. If you look, there's a little bit of liquidam back there. But I've solved the issues. And if you look back at this right side, we've uprighted those teeth. It's not a collapsed bite back there anymore. That is a tremendous load of work to do. And we achieved this in 2 rounds. So you're looking at her before and her after. In round 1, 22 trays, 5-day wear, 16 weeks. And then that is when I did the IPR between 8 and 9. I reshaped them so I would have a longer contact mesially. And then in 14 more trays, I just slid those teeth together. It took me about 10 weeks, about 2.5 months. So we've gone from before to after in about 6 months or less on Katie. And needless to say, she was very, very pleased with the change. We also had to, if you really look carefully, we had to intrude the lower anteriors here. You can just see on the before picture how close to the gum line those teeth are. Part of that was straight intrusion and part of that was uprighting the posterior teeth. But really a phenomenal effect for a 6-month case in and out. So the way I see it, Propel is wonderful. The micro-osseous perforations are wonderful because of their ease of use. There's no extra visits. I'm doing those micro-osseous perforations at the tray delivery, that first initial delivery visit. It's inexpensive relative to other techniques. Burrs, depending on how many you order them, $125, $100, $150, depending on how many you order. So relatively inexpensive. Cases are finishing 60% or more faster. Less visits for the patient. Patients love that. You know, 4 visits for my 20 aligner case. Scan, seat and propel, recall, finish. Less chair time. Happy patients. Patients have told me, you know, they've seen other people around the office or at the water cooler, and they all are in sort of aligners. And then my patients are done, and they're like, "Who is your dentist? How is this happening?" Happy patients. These are patients that go out and tell other people about what you do and how special it is for them. It sells cases. Again, you're getting more referrals for this. I will tell you that once you get past the initial obstacles of patients have fear of orthodontics, you know, they want to know how much it costs to move their teeth. Once you get past those initial questions, the last obstacle is really how long is my case going to take? When you tell a patient they're going to play with plastic trays or brackets and wires for a year and a half, you know, that's off-putting. Patients want to do this, but they're asking themselves, can I really be faithful? Can I really hang in there for this amount of time? When you tell patients in a regular case, it's about a year. In an accelerated case, it's 3 or 4 months. Patients go, bing, I can do that. I can absolutely do that. So it sells cases. Teeth move better. It is the most, I don't even know if you can tell how much I'm emphasizing. It is the most overlooked benefit to micro-osseous perforation and acceleration. It doesn't just move them faster. Patients love the faster. You are going to love the better predictability of the tooth movement, particularly when you have some of those more difficult movements. It's going to move teeth better. You're going to do less refinement. That's where some of the less chair time comes from. and I'm in control. I think the last thing I like about this is that, you know, when we're in aligner therapy, you're sending patients home and you're really no better than your patient who's compliant. So when you get a compliant patient, great, but when your patient's not compliant, anything else that we can do for acceleration kind of requires more compliance from our patient. With Micro-Osteoperforations, I'm doing it at that second visit. It's in, it's done, I've done it. They don't have to do another thing. Patients like it, I like it. And these are the benefits to this. You're gonna share this with your patients, and then they go, yeah, totally, I get this. Pricing, you know, as we said, these are about $100 to $150 a unit, depending on the number you buy. Can you charge for this? You know, yes. You know, there are people are using codes, ADA codes to bill insurances for it. Some doctors charge $500. You know, this is what I've heard. I think it's totally worth it. You've just saved someone 6 visits on a 20 aligner case. You've saved them, you're doing 4 from scan to finish. You've saved them 6 visits. You've saved them a lot of driving and parking and not picking up the kids. You've saved them a lot of time. I mean, it's advantageous. Patients always ask me what I charge nothing. By the time I've told patients that we're going to move your teeth better and faster, and I charge nothing for it, everybody says yes. I've yet to have the patient who turned around and told me, you know what, Dr. Berik, I'd really like to go a little slower, and you know, I'd like this less predictable. No, you know, so my total cost is maybe $100 or $200 for a burr or 2. My case is finished 2 to 3 visits. I have less refinement, less mid-course correction, and happy referring patients. Completely worth it. If you know what your time is worth in the chair for half an hour, you will see that this is absolutely builds the profit back into orthodontics for us. So what's your time worth? Let's assume a perfect 20 in, 20 out aligner case. I'm going to run through this quickly because I know we're nearing the end of this, but I really want to illustrate this to you guys. So we've got 20 aligners total. You're charging $5,000 a case. Say you're using an aligner lab that charges about $1,800. Your profit for the case is $3,200. One record visit, we're going to assume that takes about 30 minutes. Delivery visit for about an hour, and all your recall visits are 10 minutes. That's what we're going to assume. So in a 14-day standard wear case, you got a 30-minute record visit, 60-minute delivery, 10-minute recalls about every 6 weeks, right? 6 weeks. That's 60 minutes of recalls. 30 minutes to take off the attachments at the end. So this is an assumption, nobody's refining. Let's just keep in mind that in these standard cases, you may also have a refinement, and these numbers go down from here. So 180 minutes for your total case, assuming no refinement. So 32 divided, you're at $17 a minute, or about $1,000 an hour for your time. Well, okay, that's not bad, and we are assuming no refinement, because every time you take a scan for additional aligners, that $1,000 goes down. So we're saying, well, okay, well, that's pretty good. Bam, let's look at the way I do it. 30-minute record, 60-minute delivery, 1 10-minute recall visit in a 20 aligner case, 30 minutes, same thing for my final removal attachments, 30 minutes all in, assuming no refinements. I'm making about $24 an hour, about $500 more than an hour than the standard case, because I'm up to almost $1,500. Plus, I got an additional hour of productive chair time back. So it took me an hour less in which I could be doing other cases. I can be doing crowns in that time. I made $500 more than an hour in a standard case, and I got an hour of chair time to be productive with back. So let's run through high frequency vibration in 7 minutes. So high frequency vibration, this is the V Pro 5. This is the most simple device you're ever going to use. If you look at the U-shaped piece, that's the mouthpiece on top, and this is the assembled device. It's using high frequency vibration to seat the aligners better over the attachments. So here we go. The top portion in the first circle is the mouthpiece. The second piece is the actual motor itself, if you will. Super quiet devices, kind of like brushing your teeth with a rotary toothbrush. Again, it just kind of hums along. And then you've got a charging cable. Everybody knows how to use this. Everybody's got a smart device in their life now. It also comes with a flash drive for you, so you can track. You're going to assign these devices to patients, and so you'll know this is Mrs. Jones, and you'll be able to track her progress and her usage with it. So the delivery visit, I'm going to just throw all these up in the screen. Your Propel rep is going to have all of this stuff, whoops, one less, for your use. But basically, you're going to, I charge the device in my office so it's ready to go. So I assemble the device, I put it on the charger, we assign it to the patient, and then when I'm actually doing the delivery visit, that visit with where I'm going to put all my attachments and do my IPR, right there and then, I set my patients up. We put their aligners in their mouth. We teach them to demo, put them in and out, just like you would always do. Boom, I turn on the device. That little button here on the front of the motor is the on button. And literally, they use their first 5-minute vibrational thing right there in my office. You have a captive audience while they're vibrating away right in front of you. You can give all of your post-op instructions for your aligners. So 5 minutes a day, it automatically shuts off. You have an LED light on the bottom of it. I think there's a better view. Yeah, here's the better view. This little LED light. The device comes with instructions in it, but blue basically means it's running. You've got that 5 minute a day cycle there. You know, green, it blinks green when it's done, but it'll stop moving all by itself. Your patients, it's absolutely mindless. Patients love it. And then, of course, it tells you when it needs to be charged. What I do in my office is I charge it for them. I give it to them. I tell them with your aligners in once a day, and we plan on when that once a day is. If you leave it up to them, you know, everything happens in people's lives, and you don't get the kind of compliance that you want. But if you tell them 5 minutes a day, brush your teeth, pop your aligners in, leave the V-Pro on your nightstand, and right before you go to bed, 5 minutes. Patients will do it for you. I find really, really good compliance with this. I think part of that is just because it's 5 minutes a day. Here's the chart. So this is what your computer screen is going to look like for their compliance. So you'll be able to pull up and really monitor your patients with this. I don't tend to check every single day. I don't lose sleep over it. But what really happens is if you find a tooth that's not tracking and you need to figure out why, you're going to go back and make sure that your patient's been compliant with their V-Pro device. So here's Jamie. This is actually that movement assessment chart with the blue and black we looked at earlier. Right here you go. Here is Jamie's case. This is a very difficult case. Jamie has 7 over-retained baby teeth with no adult predecessors. And then she had trauma to number 12 and 13, and they were extracted. She split them trying to open a nail polish bottle with her teeth. So I have a kid who's genetically missing 7 teeth and now just broke some of the few adult teeth in her mouth. She wasn't my patient yet. She was under the care of her pediatrician and a pediatric orthodontist. And so when it was time to start talking about treatment, planning out her implants, and this is a full mouth restoration case for Jamie, her dad brought her back. And lo and behold, you're going to look at the lower teeth are adult teeth. Only the very small incisor is actually a baby tooth. 8 and 9 are adult, and then you can see the other ones. So we've got very diminutive adult teeth. They're very slender. Well, here's our right side, and you'll go central is an adult, baby tooth lateral, baby tooth canine, adult premolars and molar, and they're small teeth. So we've got some real challenges here. And then I got to the left side. She was under the care of the pediatrician. No one puts an appliance in this kid's mouth, and 20 and 21 super erupted right into the arch. How are you going to put a restoration here? How are you going to put an implant here? How are you going to do that? Even if you open up the posterior bite, it doesn't give you intraocclusal clearance. We had our work cut out for us, and we've got to intrude 2 adult teeth. If you'll remember from movement assessment, those were black movements. We also have additional spacing everywhere. So this case, my orthodontic plan was based on tooth position to support my post-op restorative case. And here's her lower, and you can see how small the teeth are and what kind of space I have. Here is her after. Keep in mind that it wasn't a deep bite to correct. I'm going to open her bite in back. I pulled 8 and 9 together for a bit of a papilla, but I also want to widen 8 and 9 because they're very narrow teeth. They just look big here compared to the baby teeth. Here is the lowers all lined up. I've left room between them to restore, and we know we're going to extract the baby tooth. There's room for an implant in there now. Jamie uses V-Pro device every day for me really faithfully, and look at the intrusion I have on 20 and 21. Unbelievable, full adult teeth, straight intrusion. This is a phenomenal case, and I would not have gotten here without a V-Pro device. I would have used Propel on this case equally well. She's young, she was nervous about the procedure, and I said, you know what, I've got another tool in my pocket, and here is her after. So patient materials, your Propel rep's gonna have these. I like these big handouts to give patients. They're glossy, they're clean, they're easy to understand. I love giving patients in their own hands their devices. So that, we've managed to come through right at 9 on the dot. So I appreciate all of the time and energy you guys gave me tonight. And thank you for listening. I'll take questions from you guys now. If anyone wants to stay tuned or is asking me a question, we'll go look at that now. Let me just open up my question board here. Give me one sec. Oh, let's see what we got. Is vPro, so the first question I'm really asked here is vPro okay to use as an alternative? Yeah, it's a good alternative. What I'm going to say, Paz, about your vPro is I'm going to say, if you look back at that chart we showed in the very beginning about effectiveness, vibrational technology is not as effective as micro-osteoperforation. So in a case where I would have some pretty straightforward movements, maybe a couple of rotations, maybe a little intrusion. With MOPs, I'm gonna go in 5 days. If I'm using a vPro instead, I'm gonna go 7 days with that case. I'm gonna go 7 days with that case. It's gonna make that 7-day case really predictable. If there are no blue or black or advanced movements, do you still use MOPs or do you just have them wear the aligners for 7 days? So Keith, I accelerate everything because it makes me more profitable. It makes sure, even some of those cases where maybe you're suggesting I just have some proclination, and it would be a pretty good case for organic 7-day wear. It's a great case for vPro and knock it down to 5 days. You know, I get brides, I get all kinds of patients. Nobody really wants to live in these trays for 20 weeks. If you had a 40-week case, you know, that's 8 months. You know, 20 weeks sounds better. I can do that in 2 months. That's just, it's just the way to do it, and it does keep my predictability. So I accelerate everything in some way. So I heard saying Stephanie said she's really, really excited to share the info with her team. And I agree with you. It really brings back the vavoom into starting to do ortho again. And really, you know, to your point, Stephanie, I think, you know, our teams get a hold of this and they get your excitement from doing this and they're like, what? We're gonna move cases in 3 months. Patients are saying yes more. It's really like getting your team on board with that Invisalign thing. You'll do more cases for sure. I mean, I really moved up. I have to share with you guys, like I'm doing a ton of cases. I never even thought I'd be doing 100 cases, you know, semester. And that's pretty much where I'm at this year. I'm moving probably from Platinum to Platinum Plus. I mean, it's just, because I'm getting organic referrals and patients are so happy. They're leaving you good Google reviews. Can you perform MOPs on a pregnant patient? Yes, I would, I have. I go second trimester. I always cover my botomists by making sure that I've talked to the OBGYN. I just tell them very simply, micro-osteoperforations, you just tap in the cortical bone. It's not surgical. You know, we're going to use an anesthetic with it. If they're down with that, totally fine. And if you have that pregnant patient and you have any concerns, go for it. Use the vPro. You have a really good alternative, you know, and the ortho finishes before the baby comes. It's great. Patients are really happy with it. Teeth that are being moved next to an implant tooth. So yeah, you're not going to want to do this. The question from Matt is, if you're moving a tooth that's next to an implant, so we know we're not going to move our implants, right? They're osteo-integrated. So let's say, just for illustrative purposes, since you guys are only listening and I can't demonstrate, 19 is an implant and 20 is a premolar we're going to move. I would do my MOPs to the mesial of 20, not to the distal of 20. That way you stay away from the implant tooth. How do you handle time waiting for refinement? I've had them switch back and forth between the last 2 trays. So this is really more from Jonathan. Jonathan's really asking about, is that enough to keep the effect of Propel without healing? So how do you switch on between refinement? Well, you're gonna see less refinement, but if refinement takes you past that 12-week, you're either gonna reconsider using Propel again, or you're going to be within that 10 to 12-week period for refinement. So reapplying it's so easy. I mean, you're going to have to, you numb your patient, you're probably going to need a little more IPR if you're refining, those kind of things. But I'll tell you a secret too, Jonathan, and this is killer. This is after I've done hundreds of cases. One of the things I've found is that if you look at what movement you have left, generally you've knocked out of the park all of your hard movements in your first round when you're using micro-osteoperforations or vibrational technology. So if you've got some refinement just to close a little space and you're lingually constricting, I don't reuse MOPs. I mean, if they've got the vibrational technology, the V-Pro, that never wears out, right? But if you're using MOPs, I get your point here. If they've got simple movement, I'll move them to 7-day wear with their last couple of refinement trays, and I won't repropel. It really, it's excellent. Is V-Pro, Miguel asked me, is V-Pro safe around dental implants? Yes, it is, not a concern. They're doing this with trays on, that implant's not gonna move for you, and you're probably not placing attachments. Remember that the V-Pro, that vibrational technology is gonna, I think it increases the blood flow too, makes those trays a little more comfortable, but it supersedes on your attachments. So generally you're not attaching to implants. How often do you accidentally go into the root of the tooth? Never. I've never gone into the root of the tooth, Claudia. Never. I've done hundreds of cases. I really, at this point, being KOL, I don't know how many other people have done as much as I have. I've never hit the root of a tooth. And if you do, let's stop and talk about this for a minute. It is no different. You are in cortical bone. You're in bone. So it is safe. It heals. It's not a problem. Your patient will tell you before you ever get to the root of the tooth, as soon as you enter that PDL space, your patient will go, oh, and jump. I don't mean like they're a little nervous. I mean, they'll jump for you. Simply stop advancing the device. But I've never accidentally gone into it. And when and if this has happened, research shows that this heals for us. So thank you so much, everyone. I hope I got to everybody's questions here. I appreciate all your time. Good luck with it. It really, it's changed my practice. So I hope you've enjoyed tonight. Thank you for listening.